Hi, welcome. I'm Paul Golden. I am a neonatal specialist nurse, having started with adult intensive care, moved to paediatric intensive care, then to neonatal for premature and sick babies, initially in Australia, also around New Zealand, and very much in the UK, particularly in London. So throughout that time, since the late 80s, I've worked sometimes agency or ad hoc, short contracts in a vast number of places. So I've seen differences, but there's fundamentals are the same everywhere. We're going to talk today about resuscitation of the newborn baby and the observations of it. So what else about my experiences? As a midwife, I'm at births in big units like Chelsea in London, Melbourne, Auckland, New Zealand. They could have 10,000 births a year. Then I'm at small units of 200 births. There's no medical staff around at night and we're having to do everything. I've also been an independent and home birth midwife. So again, there's that side of things and training. What I found useful for me is the marriage between midwifery and paediatrics. So sometimes paediatrics is very focused, quite rightly, on the baby, but the pregnancy and the birth have an impact on that. So being both a midwife and a neonatal specialist nurse, I say that because of the advanced training with intubation and things like this. Today, we're going to keep it simple. With the baby being born, what are the observations? There is the background that's relevant, the pregnancy, the labour and the birth, but we just focus on, does the baby need help? So this baby's been born, the cord is connected and it's flat. That's the reason we're having this conversation. I'm looking at the APGAR score at 60 seconds, not at 10 seconds or 20 or 30, but at 60 seconds. But the point of the APGAR is really reflex, tone, colour, heart rate and respiratory, not just the rate. The most important thing is the respiratory effort. So we're going to look at nose, lips and chest on a baby in general when it's born. Is it flaring with the nose? Are the lips pink? That's indicating the mucous membranes are well oxygenated. If they're not pink, is there a concern? It is more difficult in black and brown babies, but there is a duskiness, hopefully, that can be seen. The chest, this is a big area. We've got, before the chest, we've got the trachea. And the trachea is the lower part here. If it's sucking in with every breath, then that baby needs help. With the chest, we've got the sternum, the long bone here. Is that sucking in dramatically? Then that's a problem. The baby's fighting, gasping. Between the ribs, the intercostal muscles, if they're sucking in, again, that's a sign of distress. Under the ribs is subcostal. That's also a sign. So we've got subcostal, intercostal, sternum, trachea. 4 big areas of the chest to look at. But in general, is the baby struggling? Yes or no? So if in doubt, we're going to look at how to do resuscitation of a baby. I'll move straight on to resuscitation. So this baby's flat. The heart rate is less than 100. There's no tone. It's floppy, it's pale, and it's been gasping. Whether that was a breech birth or a cephalic birth, we observe some kind of gasping and then just floppiness. So we have the bag and mask. This has a valve inside, so you cannot overinflate. Standing this way, if I had the baby the other way and reaching for the baby, I would not be so effective. Bringing the baby or bringing myself to the baby this way, baby could still be attached to mother, could be on the side of a pool. I might have a board underneath the baby if I'm adapting at a home birth. But we do need resistance, not thinking about cardiac compressions at the moment, just focus on respiratory. Great distinction between newborn babies and older people is that if they're having a problem, 99% will be respiratory. With older people, it can often be cardiac. It's very unlikely to be cardiac with babies. We'll talk about that more later. So simply helping the newborn baby that's floppy, not breathing, heart rate's under 100. let's say it's 95, it's not much down. So it could come up, and it was a good heart rate before. So the nose part, on the nose, there's a C grip onto the base. I'm not going to hurt a baby by pressing the silicone mask on. It needs to be firm and well connected. The E grip, that's these 3 fingers, are on the chin. So I've got control. Now I could overextend the baby, that would not be effective. I could flex the baby, that would not be effective. I need a neutral position with the nose sniffing the air. A neutral position that's effective can only be determined if there is chest rising. So we have a dummy baby here, we can't assess the chest rising. But if, say, I've got 3 fingers here, I'm going to give some ventilation, rather inflation breaths. Some call it rescue breaths. This baby's just been born, so the lungs are full of fluid. You want to inflate those alveoli at the edge of the lungs with quite strong, slow 5 breaths. 3, 4, 5. And a tip, probably your baby is 3 to 4 kilos or more. You're going to use 3 fingers. It's quite a small mask and bag. And if you had a premature baby, you might need a smaller mask and have a range of masks. This might not be big enough for a 5 kilo baby, for example, so you could carry different masks. But the standard one is good for 3, say 2.5 to probably 4.5 kilo babies. The fingers on my right hand, the volume in here is limited. But if I had a very small baby, I might give 1 finger for 1 kilo, 2 fingers for 2 kilo, and 3 fingers for 3 and above. So that just gives an indication of the volume. The rate that I'm giving for the inflation rescue breaths, we're not focused on the rate per se exactly. It's more just get the volume in down to the base of the lung. After that, it will be at the rate of ventilation rate, 60 a minute. So that's quite fast. That's 1,000, 2,000. And I'll show you, I'll do that now. So we've done 5 inflation breaths, hasn't worked. Check everything else. Have I got to clear the airway? I may have some kind of suction with my mouth to the baby. The mother or father could. However disgusting that might be, it's a reality that's very effective. And it's their baby and they will often do it. I usually talk to parents before the birth saying, if the baby is needing help with that, maybe you could do it. However, the simplest way I have found generally, the baby's with the mother, is if the bottom, the bum, can be higher than the head. It could be at the breast, she could just be enjoying her baby, but sometimes just lifting the bum will get drainage. So you've got postural drainage because gravity is helping it. Very many years or decades ago, every baby being born was suctioned. In some countries and cultures today, they still suction every baby. When the head is on the perineum and born, they will go into the nose or the mouth or both. And that has a stimulation on the vagus nerve, which actually puts babies quite often into a bit of shock and completely inhibits their breathing attempts. So like a lot of things that we used to do, we had the opposite effect of what was desired. We have to think very carefully, is an intervention necessary? And the responsibility is on the provider and the intervention to prove that it is safe and necessary and what the risks and benefits are. So back to the baby's born, given 5 inflation breaths, it hasn't worked. I check for suction, whatever equipment I may or may not have. The parents may have suctioned, got the baby again, another 5, 2, 3, closely observing the chest wall for eyes and listening, is it escaping the air? So you notice I've got, because this is quite a small doll, I've got 2 fingers instead of my 3. But a bigger baby, you could get the 3 in. Not to overextend and not to flex, to keep it neutral. So let's say I got some air in, but the heart rate now, just for demonstration purposes, is under 60. When it's under 60, ideally I need a second person, but this then requires CPR. So we've got 2 ways to do this. The thumbs onto the sternum. The good thing about the hands under the back is you're providing resistance, and you can, going at a rate of 100 a minute, which is any nursery rhyme like Nelly the elephant packed her trunk. It's that fast. But we're going to do 3 of these to 1 breath. And the other person would do the breath. If I'm doing it myself, it's quite a challenge. You want to kind of rest this, get in a position where you can give the 1 breath. Change hands, in fact, I won't change hands. My right hand is my dominant hand, and that was more effective. So you can see it really needs a second person. It's extremely rare, as I said, to have cardiac problems in that way. Now, if we look at, for me, that's a trigger to mention what are the abnormalities. Say this baby is grey, sweaty. There could be a cardiac history. We all have a heart rate that is lub-dub. If a baby has lub-whoosh-dub, we have a patent ductus arteriosus, or basically a hole in the heart, and we can hear the whoosh. It's very difficult for experienced, qualified people to hear that. So don't focus, don't worry about that. Another thing you may hear about is a laryngeal airway that you can put into the back of the oral pharyngeal space. They're very inexpensive. You can buy them on the web. You can get training on the web very easily. This is probably the most simple and effective thing, because if you're playing with a laryngeal mask and you're not experienced with it, it's very likely you don't get it quite right. And you'll get air escaping. You'll even create a blockage. And you may be pushing down meconium, vernix, blood clots that are in the throat. Plus you need a laryngoscope. Not many people are carrying quite an expensive piece of kit with them, with the laryngoscope, and again, being trained in it. So this is really good. If you transfer to hospital in a car or an ambulance, you can still maintain ventilation breathing. That's, as we said, 1,000, 2,000, 3,000. So that's 60 a minute is ventilation breaths. You can do that. The ambulance crews are not usually experienced with babies. They probably respect whoever you are, even if you're a doula and traditional midwife, whoever's at the birth, the father of the baby. Anyone's got this, costs about 15 to 20 euros or pounds or dollars. So it's an essential piece of kit. I actually always keep 2, just in case one is broken. I'm the same with sonic aids. I have 2, just in case something happens. I have very little equipment because we don't need oxygen. It's ready for that. Many years ago, we were always resuscitating with oxygen. The air is 21% oxygen, and all the research demonstrates that's sufficient for a baby. There are times it's helpful to have oxygen for a baby, but it's not essential. And that would be more down the road when you've got to hospital, talking about home birth. You could also be in a hospital where it's busy, nobody's come into your room to help, and you have to do everything yourself. The other way, I said this way is good because you have resistance behind. You can actually move a baby, get to the phone, call an ambulance, whatever. But it is possible to just use 2 fingers onto the sternum. You don't want to be on the soft part of the abdomen, onto the hard part of the sternum, between the nipple line basically. And you aim to move 1/3 of the body, of the baby's body. So you can't just be wiggling a little bit, you have to be pumping. There's a pump, the heart. If it's not working, you are the pump. And that's at 100 a minute. But you're doing 3, somebody gives 1 breath, 3, breath, quite fast, 1, breath. If you don't have one of these, somebody's using their mouth. If they're using their mouth, they're covering the nose and mouth of the baby. With an adult, you pinch the nose, cover the mouth. With a baby, the whole thing together. And again, it's good if people have rehearsed this before birth, because you need them to be your second pair of hands. You can't do everything very easily as 1 pair of hands. So we've got that. Occasionally, if you are in a situation, you've got a neopuff, that's usually in hospital. A few people carry one with them. They may have had a premature birth or anything. The neopuff is basically like this, connected with a tube to oxygen and air in a hospital. And again, it could be you're in a busy hospital, nobody's come to help you, and you're just using your thumb like that, and it will be set 25 to 30, the peak. The peak is the high point of pressure, and there'd be a low point of pressure, ideally at 5. So even if you hold it on, it goes up to the peak, it can't hurt the baby. Now I will talk about pneumothorax. If you puncture a lung, or the baby's born with a punctured lung, thank goodness we have 2 of everything, 2 eyes, kidneys and 2 lungs, so that if there's one punctured lung, the other one can still help the baby sufficient to manage respiration, to get to hospital and get a tube put in to help the pneumothorax. What we have to be very careful, it's always better to give too little than too much, because if we overinflate, this is a small bag, but if you were using, say, an adult bag, which you shouldn't, we could overinflate the baby and cause 2 pneumothoraces. The baby cannot breathe. It's just impossible. We might be thinking about a baby that needs help, needs arterial and venous access. Well, the obvious place is the cord. So if or when the cord is cut, which it doesn't need to be cut at all, but if somebody's getting in to cut it, make sure you leave a long cord, but better still, do not cut the cord, because that is resuscitating the baby better than this in lots of situations. Unless placentas come out, mother's hemorrhage, there's some other complexities. But in general, the cord is an efficient way of resuscitating the baby. You don't have to milk it or do anything, just trust and leave it. But we also need to take care of the mother. Is she fainting? Is she hemorrhaging? Something else. So again, that's quite difficult for one clinician to manage the baby and the mother. So training other people is useful. Back to the observations of a baby. The general observations really matter by having a baseline, the next observation and the next observation. Tell us, what's the trend? Is a trend something going up? Is it plateauing? Is it going down? So if the heart rate's 60 and we're getting 80, 100, 120 and it's staying there, fantastic. If the heart rate was 120, then we've got 100, then we've got 60, then we've got 40, we can obviously see the trend. Now, we only know this trend by doing repeated observations. One of the great things about intensive care units is you've got 1-to-1 or 1-to-2 babies, and you're observing the baby so closely. Other observations include venous return. So I could use a finger on a bone, here's the center of the baby, and press for 5 seconds. Take my finger off and see the color come back. So that should return in 2 to 3 seconds. 5 or more than 5 is showing something sluggish. I cannot see inside the baby. There could be heart abnormalities, lung, any kind of congenital abnormality. Baby could have Down syndrome, could have any other kind of syndrome that's unknown. They may have had scans and we've had false positives saying everything's okay, or we may have false negatives. So if they've not had a scan, or they've had a scan, we don't really know what's going on for the baby, because birth is a massive adjustment of closing a door in the top atrium connection. It doesn't have to close completely, but it partially closes, and it will continue to close over the next week or so. But some babies have got other complex things, like a hole in the ventricles across, where the pulmonary vessels are. There can be abnormalities, there can be a narrowing. Any unusual thing which is unique to this baby, we don't know. So all we can do is maintain oxygen or oxygenation. We can observe the baby. So that's a central point. And I could observe, this is turning pink within 2 or 3 seconds, 4 seconds. Okay, I can press on the periphery on a bone and release. If I'm getting sluggish return, again, it's an indication something more complex is going on. I could feel the femoral pulse here going deep into the groin. That's telling me the aorta that splits down to 2 legs is pumping efficiently and well. If I'm getting a thin, thready pulse here, I shouldn't be. Again, it's a big concern, something abnormal's gone on. One of the things about the heart circulation is it's quite rare, but transposition of the great arteries. So what's going in the top and what's going in the bottom are switched over. Very easy surgery, but it's life-saving surgery, and somebody would help by ventilating a baby, get to hospital, having a scan. So any of the rare complex conditions are going to be evaluated by a scan, echo, ultrasound scan. Our job is just to get the baby breathing, maintain ventilation, and get to a safe place. If you're having to weigh out which hospital to go to, some people are on a border of different countries. Ideally, do the research first. Where has the best neonatal intensive care? You might think you're never going to need it, but always have that plan B, just like the red triangle in the car. We're never going to need it, but we always have it. The causes can often be a mixture of things. Could be chemical, metabolic, electrical or mechanical. So mechanical were heart defects, and metabolic can be thyroid, pancreas, all sorts of things that we don't know. And it doesn't matter what the mother had screening tests for in pregnancy. The baby is always an unknown. And if we respect that we don't know everything, however specialist or clever or what we've read, or even the consultant neonatologist comes in, they don't know this baby. So keeping an open mind is really helpful. Even when we find one diagnosis, could there be something else? Listening to the lungs, we can all do that. It's relatively simple. And we might notice we've got air entry on one side. We don't hear it so clearly on the other side. But we can mistake air exiting for just breath sounds. So again, we don't have to focus on it. Visual clues, like is the chest wall rising? Is it symmetrical? It's a bit difficult to assess that. I'll talk now about bradycardia and apnea. Let's say this baby is a few hours, maybe a day or two old, breastfeeding, everything's gone well at the birth. We're just doing a visit and we notice the baby's grey and sweaty on the forehead and grey or blue on the lips. Not the moustache area, but inside the mucous membranes is blue. So that baby needs help. Quite often a baby cannot manage to feed and breathe. So the baby's been well for 2 days. Now the baby's at the breast and suddenly it's struggling. It was probably always struggling a bit, but now it's visible, we can see it. So again, that baby may need ventilatory support, but certainly needs transfer to an excellent neonatal unit. Apnea, we all have a pause between our breaths. Babies have an immature system. They're developing their everything, thermoregulation, their temperature regulation. They're developing their breathing and their heart rate. So very premature babies would have bradycardias as well as apnea, and they're relatively normal. So bradycardia is going along at 180, then it goes down to 80. That's still a pretty good heart rate at 80. But it's not right for the baby. What's going on? Is it just a maturity thing? Just needs observation and transfer, and being prepared to assist that baby. Now, apnea, we have monitors on babies in hospitals and we set them usually for 10 seconds, depending on the baby. When they've gone home, people sometimes set them for longer. What that's telling us is it's normal for a baby to have a pause of maybe 10 seconds between breaths. So we overwatch a baby. If we're counting how many breaths in a minute, but we only count for 10 seconds, that's not accurate. We need to count for a minute. We need to step back, observe. And that's very true, again, back to birth. The APGAR is a 60-second thing. And the neonatal life support resus that I basically already shown and just refer to this, does say up to 90 seconds. Now, if you imagine how much information you would get from 3 YouTube 30-second videos, you can have 3 of those, that's 90 seconds. People are quite often diving in at 10 seconds, 20 seconds, and we make the baby worse. We can wait, observe. The baby has close contact with the mother has close contact with her baby, possibly some postural drainage. Sometimes the most subtle is the most profound. And the baby just jumps a bit and gets to do the first breaths. It's not done any breathing ever. That can be enough. Sometimes drying. I have colleagues that are very vigorous. I can't say what's right or wrong. I myself don't need to be so vigorous. Naturally, I'm gentle, but I find the subtle is the most powerful with the baby. And not taking babies from mother, because there's a big connection with the mother who needs her baby and the baby needs the mother. It really is that simple. The skin to skin, the warmth, it's not just mechanical, it's energetic, it's everything. So the baby does need that. But sometimes we have to help. A mother might be so enjoying the ecstasy of birth that she's suffocating her baby in her breasts. We might just have to remind her to turn the baby's head to the side. I'm quite a fan of making sure there's no cloth here. If women have got bras and things, babies' heads against the fabric. That, again, is quite different from the softness of skin. and might need to help the woman because she's just given birth. She's in her instincts rather than her thoughtful mind. So yeah, going back to normal things, we can just breathe on the baby, wipe it, maybe clear something out if we have to, but mostly skin to skin is going to be the gentlest and most powerful way of helping a baby when they've been born. If after a minute or even after 30 seconds, if you're really worried about a baby, you could start to evaluate, start to help a baby, it would be with the inflation breaths. If that's not sufficient, you'd move on to ventilation breaths and just keep doing that for the transfer to hospital.